Good evening, comrades. Dr. Bwenje here. As promised earlier, we're supposed to do 4 videos according to the poll that we did, and then I was supposed to do these videos to show you exactly what kind of videos that I'd want you to make to maximize the learning, and also the information we can extract from your presentation when you share. But then actually my true desire is we have videos like really recorded with someone presenting on a whiteboard and some good pictorial or visual illustrations of what they are presenting. But I think for the start we can do this, and then we build on that. So anyway, management of deep bite. By definition, deep bite is basically an excessive overbite in centric or habitual occlusion, or when a patient bites, they'll have their point of maximum intercuspation. We have an excessive vertical overlap of the maxillary and the mandibular incisors. So ideally, an overbite should be about 5 to 25% if it's expressed relatively, though absolutely it's put in millimeters, so ideally it's supposed to be between 2 to 4 millimeters. Or you can actually express it also more qualitatively by explaining in detail how the incisors relate. But we know in deep bites, the mandibular incisors, the incisor edges always lie apical to the singular of the maxillary incisors. Now this relationship may be atraumatic or traumatic. Now in traumatic cases, we have the mandibular incisors actually contacting the soft tissues of the maxilla different points. But with our traumatic ones, we have that excessive overlap, but there is no trauma to the soft tissues. Okay, we shall get into that later. Now, overbite clinically becomes a problem if it exceeds 40%, or if the maxillary incisors cover up almost half the labial surfaces of the mandibular incisors. And actually this malocclusion doesn't really happen in isolation. You'll find it in class 1 malocclusions. You could also find it in class 2 and also class 3 actually. So it doesn't really, you don't find it happening in isolation. It's always with a combination of bunch of other malocclusions, which can also be crowding. So when you're managing this case or deep bite cases, you always have to put the other malocclusions also in mind. And deep bite cases is actually the most common malocclusion in a vertical dimension of space. Now the other malocclusion being overbite. Overbite about constitutes almost only just about 5% of malocclusion in the vertical plane of space. Deep bite takes 95%. And globally, deep bites have about 21% prevalence. Now, and it's also very actually common in Caucasians, or the white people, the Bazungu, and 75% of cases almost after crowding deep bite cases, and it's one of the most difficult cases to manage. Most times we are used to handling crowding and simple cases that don't require extractions or some serious mechanics. But now every time you see a deep bite case, especially in an outgrowing patient, you know you're dealing with something really heavy. Now these are illustrations of the deep bite. These colors that you see, yellow is the ideal, then orange is acceptable, let's say. But red is now where we have issues, like it's really deep now. On the left, you also see that illustration, but now in the left, it's done in terms of millimeters, and then on the right, you see it in percentages. Clinical features of deep bite. Of course, when you receive a patient, you start off by inspection, extraoral inspection, before actually even see the patient on the chair. You start by observing the patient, and extraoral features, these are the ones you'll see. The patient will have a short square face. Why? Because of the shortening of the lower anterior facial height. And then the patient is also going to look like they don't have teeth. When in the fully dentulous patients, usually they have those features, but protrusion of the chin, and then shortening of the anterior lower facial height, and skin folds happening around the mouth, perioral skill folds. That makes actually give someone an appearance of looking old. So actually, in short, we would just put all this and say it's a short face syndrome, and all the other features that surround that, as you can see here. The intraoral features will have that broad maxillary arch. Usually in deep bites, the palatal vault is not deep. It's usually shallow, and the maxilla tends to be a bit wider than the mandible is. So actually, it looks like the maxilla is engulfing the mandible, like the mandible is hidden behind inside the maxilla. So in certain instances, actually, you might not even be able to see. If on full occlusion, you may not be able to see the patient's mandibular incisors. We shall look at those classifications also later on. And depending, of course, on the cause of a deep bite, you'll see things like supraeruption of the incisors, or they are not supraerupted but just longer than normal. The molars are in infraocclusion, and you also see some other abnormal muscle activity like lateral tongue thrust, and all those features that will cause a deep bite occur in the mouth. But the other notable feature actually in intraoral is an excessive curve of speed. That's the thing that you'll always see, and you'll also see in incisors the overlapping, the excessive overlapping, excessive curve of speed, and molars being in infraocclusion. Basically, that's what you'll see in a deep bite. And extraorally, you'll see a short lower third of the face. It shortens. It's like we call it a short face syndrome. Etiology is hereditary, genetic. Those are the genes: BMP4, COL1A1, and a bunch of other genes. Actually, studies are still being done on these genes, and these genes affect the skeleton. That can cause actually abnormal rotations of the maxilla and the mandible that result into the deep bite. These genes can also affect the dental velar processes, causing excessive growth of the anterior of the labial segments at the expense of the buccal segments. The labial segments are the inside, the anteriors. The buccal segments are the posteriors, premolar, molars, labial segments, canines, incisors. It can also be acquired. Usually hereditary is associated with skeletal deep bites, which is actually very difficult to treat. The acquired ones is a deep bite that someone gets later on in life. And this can happen from occlusal occlusion that causes loss of vertical occlusal dimension. Lateral tongue thrust. Now, we know what the tongue, soft tissues interfere with the growth of teeth or eruption of teeth. And if the tongue is always in the space between the molars are not going to erupt their ideal heights. So you'll have collapse of the bite, the anterior bite, resulting in the deep bite. And then also we have issues like secondary occlusal trauma, especially in severe periodontitis. You notice those instances where the incisors migrate pathologically due to weak periodontal support, and then someone ends up with a deep bite. In hypertonic masticatory muscles, especially someone who likes to clench, you know that clenching has got an intrusive force on the molars, so they can also deepen the bite over time. Classification of deep bite. This is the classification like we explained earlier. It can be developmental or it can be acquired. Now, developmental is something that someone is born with, So these also illustrations on the deep bite. I think you'll find time and get this video and work look at it closely. Like I said earlier, deep bites can happen in class 1, class 2, and class 3 malocclusion. So deep bites basically that vertical overlap, excessive vertical overlap of the incisors. So also the classification according to origin, we have skeletal deep bite, we have dental alveolar deep bite. So with the skeletal deep bite, the key feature is forward and upward rotation of the mandible, causing deepening of the bite. We know ideally the mandible is supposed to grow downwards and backwards. It has to rotate clockwise, but now in this case it rotates anti-clockwise and causes bite deepening. It can also be dental alveolar, which is usually incisor supraversion or eruption. Or it can be functional classification. True with the true true deep bite. In this we say it's true because the problem is actually coming from the posterior teeth being in infraocclusion. So the incisors are actually of normal height, but now because of that shortening of the posteriors, they tend to overlap too much. Now that's a classical deep bite. Now with the classical deep bite, you'd expect to actually have a very big freeway space. Now with the pseudo, it seems like there is actually a deep bite, which is you see it clinically, but it's not coming from infraocclusion of the posteriors. It's resulting from supereruption of the incisors. Then the extent of the deep bite, sometimes you can have a complete deep bite or incomplete deep bite. Now a complete deep bite is total covering of the incisors, the lower incisors. You don't actually see them. So a patient actually looks like they've swallowed their mandible. You don't see that, sorry, they've swallowed their mandibular incisors. Actually, they almost look like they don't have any lower teeth. When they occlude, the maxillary incisors completely obscure the mandibular incisors. So we call that 100% deep bite. In an incomplete deep bite, you see part of the mandibular incisors. The maxillary incisors completely obscure the mandibular incisors. You see part of it. So these are different illustrations, schematic representations of the different malocclusions. So you can have just dental alveolar, or you can have skeletal, or you can have a combination of both, as illustrated here. Now with the traumatic deep bite, now remember the other deep bites we're talking about earlier on is there is no occlusion, like the overlap is there, but there's no contact between the incisors and also with the soft tissues. But now with the classification of deep bite, traumatic ones, we have 4 classifications according to Ackerley, and these are the ones you see. It only gets worse as you keep progressing. Now with the first one, the mandibular incisors only contact the palatal mucosa. The second one, the lower incisors contact the marginal gingiva of the palatal, the palatal marginal gingiva of the maxillary incisors. With the third one, the incisors contact the palatal gingiva of the maxillary incisors, and the maxillary incisors contact the labial gingiva of the mandibular incisors. Now with class 4, which is actually the severest of this traumatic deep bite, is you actually have the incisors rubbing onto each other. So you might actually see wear facets, like points of wear, enamel wear on the palatal surfaces of the maxillary incisors, or incisor wear, or labial surface wear on the mandibular incisors. Actually, this is very severe. I've seen a lot of these cases. And clinical effects of deep bite, of course, deep bite comes with issues, incisor wear, especially incisor wear and periodontal damage in traumatic deep bites, like explained earlier, and also deep bite because of that excessive curve of speed. Usually, patients with deep bites tend to have mandibular issues. They have clicks, mandibular deviations, and whatnot, because in function, there's a lot of interferences, especially in chewing. There's a lot of interferences, so the teeth tend to find a more comfortable position in function, and that of course affects the TMJ. The TMJ changes, and start hearing clicks in the TMJ. And also people with deep bites always struggle to function, especially chewing, and also speech can be really hard with people with severe deep bites. And also not forgetting aesthetics, the smiles in these people is horrible. Aesthetics is really terribly affected with deep bites. Investigations, this includes patient history. Of course, you're looking for habits, history of dental history, medical history, and all that. Trying to find any other systemic diagnosis that may be connected to malocclusion. Sometimes this malocclusion is actually syndromic, so you need to take history to be able to know if these malocclusions are happening in isolation or part of the syndrome, which is systemic. Patient examination, this is evaluating palpations, inspections, all that, the general. Photography is good for the records. Models for model analysis. Models actually, there are features of deep bites that you may not be able to appreciate so well in the patient's mouth until you take models. So let's take models. Take models, it's very good. It's good to have the patient's mouth in your hand so you can actually look at it from all angles in 3D and appreciate the full aspect of your malocclusion. OPG is obviously standard. Lateral cephalograph is very good for identifying skeletal deep bites. These features that you'll see in skeletal deep bite. For example, when you do cephalometric analysis for someone in a deep bite, you'll notice that they have a lower mandibular plane angle. The entire incisor angle is also elevated, and their posterior facial height is greater than the anterior facial height, features like that. And also not forgetting on the lateral, you'll find that the occlusal plane lies below the oral commissure or the mouth, so the opening of the mouth. So that actually also informs you on what you should do. And if you look at patient examination, you have to address a lot of issues that we shall look at it later on. Like when you're doing that examination, you're doing these clinical considerations, you're doing your assessments, you try and come up with a diagnosis. Look at the soft tissues, the interlabial gap is very important. Now you'll find a higher lower interlabial gap in dental alveolar deep bites, and a high interlabial gap in skeletal deep bite. So actually all these features here show you on how you should manage the case. Okay, and we also have things like lip length, lip tonicity, and smile lines. Growth considerations, the modalities, the approach to treat management is different for patients who are growing and patients who are not growing. And for growing specifically, I'm talking about those who are in mixed dentition period. That's why you have a lot of growing happening. That is pre-pubertal or at puberty, between there, before puberty and between the early mixed dentition and the late mixed dentition period. That's a perfect time to handle these growing patients. Beyond that, you don't have a lot of growth potential left. There's not much changes happening, so you really don't have a lot of growth to work with, to manipulate, to be able to produce your results. And also you look at severity and cause. Now for severe deep bites, really those are complex ones, which are about over 4 millimeters or over 50% overlap, are not the same as those that are below 4 millimeters or less than 40-50% overlap. The management criteria is totally different. And also you look at the freeway space available. This actually also very useful, especially if you are going to have to extrude the posteriors. Okay. Two major approaches to this management. You can either extrude the posteriors or intrude the anterior, or you can do a combination of both. Sometimes you may just need to procline the mandibular incisors, especially if they're retroclined. You can just procline them to fix the issue. And like I said, the choice of treatment is based on the cause, severity, growth potential that we have, and then the other vertical occlusal dimension. Now, these are the ways you can manage. You can either extrude the posteriors or intrude the anteriors, a combination of both. Posterior extrusion is good for ingrowing patients, first of all, because the condyles are still developing, they're still remodeling, and they can accommodate more increase in vertical closure dimension. And also, if the lips are redundant, I mean, someone looks like you have old age, the lips are too long for the face. There you have room to elongate the face without causing excessive opening of the bite, and end up with move from a deep bite an open bite, which can actually happen if you don't plan your treatment right. Incisors intrusion is required in vertical maxillary excess, large interlabial gaps, because if the labial gap is wide and then you extrude posteriors, the interlabial gap is going to widen further, and that's going to cause aesthetic issues. Of course, steep mandibular plane. This is for vertical growers. Now, with vertical growers with a steep mandibular plane angle, you don't want to extrude any posteriors. You want to leave the posteriors as they are, and you just deal with the anteriors. But of course, also, if you're going to intrude anteriors or extrude posteriors, also going to find a lot of factors. So, modalities of management are 3, like in any orthodontic case. Camouflage. Now, in camouflage is the bite is not severe, and surely done in non-growing patients, because you're just doing dental alveolar modifications, and basically in this case you do absolute incisor intrusion. Now there's what we call relative and absolute incisor intrusion. Absolute incisor intrusion is where you actually do actual intrusion of the incisors, okay? And with relative intrusion, you're extruding a posterior so it will look like you intruded the incisors, but actually the occlusal plane has been flattened because you've extruded the posterior, not intruding the incisors. Now for this, you use fixed appliances. You can use clear aligners. Growth modification. This works so good with growing patients in the early to mid-late mixed dentition. For this case, you can do incisor intrusion, or you can do posterior extrusion, or both. Depends on the soft tissues and the vertical closure dimension that you have. Functional appliances work here good. Myofunctional appliances to be exact. And then also orthopedic appliances can work so well in this case. Now these two appliances categories help modify soft tissue and hard tissue growth to be able to correct or reverse deep bite. Orthognathic surgery is for severe deep bites in non-growing patients, where people are above 18 and so people who no longer have any new skeletal growth happening. This happens for severe deep bites, about 5 millimeters, and you can do surgery on the maxilla, on the mandible, or both. But still, you need to do orthodontics to be able to finish up the alignment of teeth after the surgery. So you still need to go back to do putting braces and all that after doing the surgery. And actually also have to do braces before the surgery to decompensate. Decompensation is, when now orthognathic surgery is recommended in skeletal deep bites when the apical base, the jaw is made up of the dental alveolar process and then the apical base. If the apical base is deficient, the dental alveolar process always tries to add that or accommodate or compensate for that deficiency or excessiveness by changing it, remodeling and all. So for you have to position the teeth in an ideal position before you do the surgery to reverse that compensation. And we shall talk about, I think we shall have a topic about compensation. It's on because it's really important, it's broad, and I can't just discuss it all here. Appliances and biomechanics. Appliances, we use removable appliances. Anterior bite plane is good. This is recommended in growing patients, mixed dentition period. Clear liners are good for adults, but these are all removable appliances. Fixed appliances, we can have intrusion arches. Now, intrusion arches serve to intrude the anteriors. Many types of intrusion arches. A good example is Ricketts utility arch. We have the Connecticut intrusion arch. We have Boston's intrusion arch. We have a bunch of them. We have modified Nancy appliance, which has a fixed biplate on the anterior maxilla palate. We have reverse curve of sphere arch wires. We have temporary anchorage devices, tabs or micro screws. With function appliances, we can use activator, bayonetter, functional regulator, or twin block. Now, activator can do both posterior extrusion and incisor, intrusion, but bayonetter, functional regulator, and twin block basically work on posterior extrusion. Also good for growing patients. Extraoral appliances, a good one is cervical pull headgear. This is good for distalizing posterior maxillary sixes and also extruding them to correct the deep bite. So actually this can work in class 2 div 1 where I'm trying to correct the deep bite plus also the overjet at the same time. Very good one. Habit breakers, especially if the patient has lateral tongue thrust. You need the posterior tongue there to keep the tongue away from the teeth so that the teeth can be free to erupt. The molars can erupt freely without interferences. Forces, you need about 10 to 25 grams for each incisor. Now you need more force for central incisors than you need for lateral incisors. So for lateral incisors, I would recommend 10 to 15 grams of force per tooth, and 15 to 20 grams of force per tooth for central incisors. 60 grams for canines. Now the differences of these forces is dependent on the total root surface area. Lateral incisors have a low root surface area, so you don't need as much force to intrude them. Now canines on the other hand have a very long wide root, so their root surface is quite high, so you need a higher force to be able to intrude them. You need actually a lot of grams for cervical pull headgear. You need 200 to 300 grams on either sides applied for 14 to 16 hours a day to be able to extrude the posterior with the cervical pull headgear. Now for the other ones, the incisors intrusion, you need the light continuous forces. For these extraoral appliances, orthopedic appliances, you need heavy intermittent forces. That's why you don't wear it all day long for headgear. You just wear 14-16 hours. And also this headgear works good for growing patients, not very good, not effective in ungrowing patients. If a patient is already outside the mixed dentition period, bad idea to use this one. Now you'll have to consider intruding incisors actively and you leave the posteriors as they are, unless you really have to extrude the posteriors. Now in instances where maybe the posterior or the vertical height in the molar region is lost because of gross caries, you've seen those people where they completely have no molars, they just have premolars and incisors, and some actually who don't have premolars at all. They don't have premolars and molars completely. They lost all these teeth to caries, so they end up with a deep bite because there is no teeth at the back to hold the jaws apart. Retention is recommended actually for years with deep bite correction. According to studies, we have about 10% relapse rates for deep bite correction, so you need to retain. Actually, it's recommended you put a biplate on the maxilla along with the labial ball. The hole is retained actually the biplate in the maxilla for a year or so, and then permanent retention or fixed retention on the mandibular incisors to prevent them from super erupting after you disengage the appliances. Vertical growers have a lower tendency to relapse compared to horizontal growers, because actually if you look at the horizontal grower, now with the horizontal grower we have the mandibular plane angle being almost flat. So with horizontal growers, even the musculature around the jaws itself promotes the deep bite. I mean, usually if you look at the horizontal grower, people with short faces, you notice that their masseters are usually so prominent and active and strong and powerful. So these powerful masseters always maintain the deep bite, actually can cause a relapse if you don't do good retention. But with vertical growers, where the vertical occlusal dimension is okay, the masseters are usually so weak, so they can't really produce that much spring back that will produce the relapse. Like I said, with relapse rates about on a 12-year follow-up period is about 10% from the studies. But like deep bites actually are not so well studied that much. There's not a lot of articles about deep bites. I've been doing a lot of research on this, and they keep saying that really that the management is based on your clinical features or clinical findings. There's not one effective way to manage a case. So every case has got its own issues, so you have to be able to diagnose and analyze all these issues properly and put them into consideration before you come up with a treatment plan. I'll give you some case examples. Here, figure 7, you'll see how the intrusions were done and the changes before and after. You can look at them afterwards. And then we have a case here where the picture actually you see here, these are intrusion arches that are meant to intrude the incisors. Okay, like you can actually see, if you look at this case, it's almost a 100% deep bite. You almost don't see the mandibular incisors completely, like they're gone, you know. So in this case, and also the smile is gone, so you need to intrude the upper incisors so you can improve also the gum display on smiling. So actually, speaking about the smile lines, there's we have the normal smile line, a high one, and then the low one. Now, the normal one, when someone smiles, you expect to see about 75% to 200% of the maxillary incisors displaying. Now, in women, on full smiling, actually part of the gums can show in women because their upper lips are usually shorter than in men. I don't know if God designed them like that, so when they smile, you really see that glow. I don't know, but in women, there's more incisor display in smiling than in men. Actually, in females, you have 100% incisor display plus about 1 millimeter or 2 of the inside of the gingiva also showing. That's okay. In a low smile, you have less than 75% of the gingiva show low smile line. Now in a high smile line, that tends to gummy smile, we have 100% of the incisor display plus more than 2 millimeters of the gum showing. So actually you see someone smile and gummy. If you look at this case here on figure 8, see how the smile is? This smile is very, very high, and after treatment it was improved. Now you actually see after treatment, you see that it has moved from 100% plus over 2 millimeters of gum showing on full smile to only part of the gingiva displaying, about 1 millimeter displaying. So see, the results are really good. Now, these are not my cases, I just borrowed them to use them for demonstration. So colleagues, this is the beginning, and this is how I'd want us to do these videos, but because of course I would have loved to have camera, audio and all that being recorded, and we do a good shot and with me demonstrating on the board, and then we have short videos and pictures, come in between there to illustrate more, and then I continue with the demonstrations. But we didn't manage to raise that money, and I think hopefully with time we shall be able to raise the money that we need to be able to do those kind of videos that actually are more illustrative. But I think also this with PowerPoint presentation is also good for the start, right? It doesn't require a lot of money, just it's time, a few hours, and some commitment and data to be able to produce. So thank you very much again. I think next we shall do open bites, and then we shall move to crowding, and then we wind up with the last case. Thank you.